You're at the cutting edge of cardiovascular sciences. I'm John Cook. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist Research Institute and Hospitals. And we have a wonderful speaker for you today. Dr. Shaw is going to be introduced by my associate, Dr. Lee Lai, who is a junior faculty member in the Department of Cardiovascular Sciences. Dr. Lee Lai, would you introduce our guest?
Sure. It's my honor to introduce our speaker today. So Dr. Robin Shaw is director of the Nora Echo Harrison Cardiovascular Research and Training Institute at the University of Utah, where he's also the Nora Echo Harrison Presidential Endowed Chair, Professor of Medicine, and Adjunct Professor of Biomedical Engineering. Dr. Shaw earned his undergraduate degree at Brown University and his medical degree and doctorate in biomedical engineering at Case Western Reserve University. He received his internal medicine at cardiovascular diseases trainings at University of California, San Francisco, where he remained on the faculty as the investigator at the UCSF Cardiovascular Research Institute. In 2013, he moved to the University of California, Los Angeles, and Cedars-Sinai Medical Center until 2019, when he joined the University of Utah. Dr. Shaw is well funded by NIH, and he's an established investigator of the American Heart Association and a member of AHA's BCVS Leadership Committee. Dr. Shaw's clinical interest in patients with cardiovascular disease, including advanced heart failure and arrhythmia syndromes. By doing translational research in his lab, which focused on basic myocardial biology, Dr. Shaw's group has developed gene therapy solutions for heart failure and arrhythmogenic cardiomyopathy based on the protein his lab has discovered. So today, it's our great honor to have Dr. Shaw join our show, and I can't wait to hear the great work that's happening in your lab.
Welcome, Dr. Shaw.
Thank you, Dr. Cook, Dr. Lai. It's a real pleasure to be here. I caught some of the advertisement right before. It's kind of intimidating to be here, if I'm going to be honest. So thank you for letting me join the show.
Absolutely, absolutely. We're going to be hearing about your great work, your research in a moment, but I know that you've also have a great interest in training, and you run the training there for cardiovascular research in Utah. Tell us a little bit about that.
So it's a good question. Like a number of us, yourself included, we have the pleasure of being involved in both basic science and the clinical world, and the real opportunity and the challenge is sort of what to do with those two different fields, two different universes these days, and the answer, at least personally, is to try to bring them together as much as the wet lab is far away from clinical care at this point. It's quite possible for scientists to really be informed by clinical needs and clinically related questions. And the converse is true as well. It's very possible that clinicians can do great science. And the model that we urge at the CVRTI at Utah is that we try to team up scientists with clinicians. And that's a model. It started at UCSF. We did it down in Los Angeles. And it's worked very well in the past, in that busy clinicians who have spent enormous amount of time becoming the top of their field haven't had the same amount of time to really become basic scientists. And similarly, basic scientists never trained clinically, but the scientist needs the clinician, and the clinician needs the scientist. And by pairing people together, I've found is that it's it works very, very well. There's little competition between the two, and it's pretty much a win-win situation. So if I can do anything as a physician scientist in the remaining years that I am one, I'll do what I can to bring the scientific and the clinical worlds together.
I love that philosophy, and of course we ascribe to the same philosophy here, pairing our clinicians and investigators. I can immediately think of several great examples of that, but we need more, right? And it's great that you're continuing to train people to work together like that. Let me just, speaking of working together, we do have folks online that are listening, Dr. Shaw, so I just wanted to let them know how they can ask questions during the show.
Absolutely.
And what they can do, they can text DeBakey to 37607. So dial 37607, text DeBakey, and then you can just text in your message. That's a fairly simple way to do it. Or you can go online to PollEV, that's POLLEV.com, and enter DeBakey, and then respond to that activity. So the NIH does help with that kind of training, with training grants and such. Do you currently have a training grant at Utah for this purpose?
Yeah, we're very fortunate. We have a T32 training grant. It's as you know, it's the backbone of NIH-sponsored training. I think right now we have, I hope I'm not misquoting, either 5 or 6 slots annually on the grant, and they're 2-year awards. What's wonderful about the T32 award is it just gives folks protected time to do what they need to do to develop. If in my opinion, time is the most valuable commodity of all. It's not sort of money to complete a project. It's not having a great idea. It's being in the right environment and having the time to really sort of cook in that environment. And so the training grant at Utah is entering its 37th year. Obviously, I wasn't the one who initiated it. I've been fortunate to continue it to establish Dracos, who's at the CBRTI at Utah and a leader in myocardial recovery. And so if we can continue to drive home the message that a focus on basic biology is valuable with strong input from clinical research, then I think that's a formula that we really, I know that's what's done at Houston Methodist, and that's a formula that really should just continue in this country, as hard as it is. I'm in environments where having clinical insight is honestly, and this is a bit historic, but was frowned upon. I've been told in my career, Robin, you're a great scientist. I don't know if that's true or not, but Robin, we accept you as a scientist. Why don't you just keep focused on the science and leave the clinical medicine to clinicians? And of course, the reverse is true, whereas clinicians, feel like science is too far removed from their day-to-day needs and their patients' needs. And so if we can keep the message, so keep the torch, if you will, of combining wet lab science with sort of clinical oriented questions. And one of the way we do that is through the training grant. And, thank God for it. That really 232 award has done wonders for a number of people.
Well, that's
myself included.
That's beautiful. And now I think what we'd like to turn to is your presentation of your own research. You've done some nice work in arrhythmogenesis, the understanding the mechanisms of arrhythmogenesis. So we're looking forward to hearing about that. And Dr. Shaw has been kind enough to allow us to ask questions as we go through the presentation. And so we'll also take questions online as well. So please send in your questions. As I said earlier, you can simply join by text DeBakey to 37607 and text in your message, and we'll ask Dr. Shaw your question. So maybe you can go ahead, Dr. Shaw, and pull up your presentation, and we'll go ahead and get started.
We'll do so. One second, let me share with you guys.
And here we go.
Here we go. Okay, yeah. Is that format working?
Perfect.
Perfect. Okay. So again, I love the format, and thank you for the invitation. As Dr. Cook mentioned, there's a couple of molecules that my group has discovered or cloned or identified in the course of the career, and we've been actually recently focused on asking the more clinically relevant question: what do these molecules do? I'll touch on the arrhythmogenic cardiomyopathy molecule, GJ120K, just at the end of this presentation. And for the arrhythmologist, again, happy to discuss it in length. But in the initial part of the presentation, I'll be discussing another molecule that's a little further along in the translational spectrum, and this is cardiac bin-1. And so the first part of the presentation will be about heart failure, and then I'll finish up with the arrhythmia work. So with regard to heart failure, the title of the presentation is Treating Heart Failure as a Disease of Failing Heart Muscle. And talking to sort of the house that DeBakey built, it's a bit humbling because, of course, when we discuss the arc of advanced heart failure care, it really starts about 56 years ago when the first heart transplant was done. This was, of course, Christian Barnard in South Africa in December of 67, soon followed at Stanford, and then, of course, by DeBakey at Houston Methodist. DeBakey spent a lot of time on pumps and support pumps. The Jarvik heart is a personal favorite when you're coming from Utah, because not only is it the first long-standing total artificial heart, but it was implanted in a Utah man at the university. Soon, the total artificial heart, or biventricular heart, gave way to LVAD, single chamber support, left ventricular assist devices. And if you can see my mouse, let me see if I can get a little bit of a brighter pointer here. It really sort of, as we headed into the 90s, historically, these are the mechanical solutions, if you will, that are still present today: the heart transplant, the total artificial, and then the left ventricular support devices. Going further into the 90s, really started the big clinical trials for heart failure, initially with beta blockers, and then it spread to angiotensin inhibitors and aldosterone inhibitors. But essentially, medical therapy began in earnest for heart failure in the 90s with the approach to block the neurohormonal systemic response to failing heart. So conceptually understand that the medicines of today were really not designed to help the heart, but they were designed to help the body from beating up the heart as heart failure progressed. Additional therapies have been added in the last 20 years. Resynchronization really came onto the scene in the early 2000s. And then in 2006, sort of a niche academic field started to develop out of England. Several Dracos who do a lot of this work now in the United States. And that's myocardial recovery. The concept that if a so-called end-stage heart on an LVAD can actually be recovered, it doesn't have to lead to a heart transplant or permanent LVAD implantation. The idea is that failing heart can come back. The SGLT2 inhibitors have been added in the last 8 years, and the jury's still out for what the SGLT2 inhibitors do. Likely a big component of them is Vascular. And then the company Cytokinetics really had a landmark moment where they said, let's try to actually improve failing heart muscle for patients with heart failure. As many of you know, the Cytokinetics calcium sensitizing agent for myosin ended up not, the FDA felt like it didn't meet satisfactory endpoints. But nonetheless, I feel academically it's a watershed moment. And what I hope to convince you over much of this talk before we get to the arrhythmia work is that when we work on the muscle and we actually improve myocyte architecture, we can actually improve failing heart muscle. And so I'm talking specifically now about CBN1 gene therapy, and we can, and biologically what we're doing is restoring T-tubule membrane microdomains. And so I have just about 3 or 4 sort of scientifically oriented slides, and then I'll get to the large animal data. And so failing heart muscle is not just, when we say muscles remodel in heart failure, it's not just that the whole organ remodels, it's individual myocytes. We all have about 2 to 4 billion heart muscle cells or cardiomyocytes in our main pumping chamber in the left ventricle. And typical cardiomyocytes are highly organized. This is calcium antibody. It could be any number of them, but this calcium antibody of a human ventricular cardiomyocyte taken from somebody who died from non-cardiac cause, essentially had a normal heart. And what you can see is this calcium channel staining highlights T-tubules, which outline every 2 microns, outline the sarcomeres, the contractile units. On the right-hand side, the same antibody, the same approach, but this is a cell, a heart muscle cell, a cardiomyocyte, isolated from somebody with end-stage heart failure. And the protein is by and large about the same, but more importantly, and this is a critical point from the presentation, the cardiomyocytes that are failing are disorganized. And when they're disorganized, efficient excitation contraction coupling cannot occur. Effective calcium transients are not generated, so efficient systolic contraction, diastolic relaxation does not occur. So if we can actually improve the organization of cardiomyocytes in disease, we can actually improve their function. At least that's the idea. And really what we're talking about when I say organization is trafficking. If we can improve how how proteins are trafficked or moved around in cardiomyocytes, we can actually improve their function. So here is a series of electron micrographs of looking at these T-tubules. These are individual units separated by the thick black lines or sarcomeres. And if you look at sort of the so-called what we call lakes, that's sort of looking at these T-tubule membrane invaginations from the top down. So we're basically seeing a slice or cross-section of the T-tubule opening. And what you'll see is that with failure, T-tubules tend to enlarge. They lose their morphology, and with that, they lose the ability to hold the proteins that they collect, the important calcium handling proteins, so-called calcium handling machinery. What's interesting in this mouse is we didn't actually cause failure. We took away a protein called BIN1, a membrane sculpting protein. And over the course of our studies and a major sort of milestone paper in our studies about 10 years ago in Nature Medicine, we cloned the cardiac isoform of BIN1, this membrane sculpting protein. And so essentially we identify the protein, not that causes T-tubule generation, but in fact causes these tiny microdomains, and these microdomains which are lost in heart failure. Here's a 3D reconstruction of slices looking down. You see the membrane, T-tubule membrane is highly sculpted, and these microdomains, these baskets, if you will, are what collect the calcium handling proteins so vital to calcium transients and contraction and relaxation. And these microdomains are lost in failing hearts. And they're lost in failing hearts in acquired and genetic cardiomyopathy. They're lost in HFpEF as well as HFrEF, as well as diabetic cardiomyopathy. When the heart fails, these microdomains are lost. And then in the sort of the last two mouse slides, as we get to bigger animal models, Here is again electron micrograph of T-tubule openings. And in this particular mouse, we created heart failure, primarily a diastolic dysfunction, by installing an isoproterenol emitting pump. And what you can see is the loss of the morphology of the T-tubule openings. This is enlarged on the right. And when we give CBN1 as a gene therapy, as an exogenous therapy to return T-tubule morphology and microdomains, what we see, and I'm not going to show you all the data because it's already well published, what we see is a return of cardiac function and actually an improvement in mortality. So we not only can forestall heart failure, we can actually recover failing hearts. And then in the last sort of mouse slide, if you will, I want to show you one particular protein, and that is SERCA2A, because many of you will know SERCA2A has been studied as a gene therapy. So cardiac BIN1 is not a calcium handling protein. It's a architectural protein. It affects protein movements, protein trafficking. And when we restore the architecture of cells, the rest of the calcium handling proteins follow along, if you will. This is SERCA2A, which helps calcium come back into the sarcoplasmic reticulum, helps diastolic function, and then subsequent systolic function. And what you can see is disruption of SERCA2A organization in, say, this isoproterenol model. And then when we give CBN1 as a gene therapy, we restore organization of SERCA2A. SERCA2A levels come up, and even more importantly, we restore the organization. The same occurs for calcium channels. The same occurs for renin receptors. So our overall model here, and this is sort of a take-home model, if you will, these T-tubule invaginations are not sort of smooth T-tubules. They're richly folded and form microdomains, and it's this cardiac BIN1 protein that makes these microdomains, and around it, all the key calcium handling proteins localized. This architecture is lost when the heart is insulted, and that insult could be ischemia, hypertension, diabetes, toxins, infections, and we've checked each one, as well as, of course, genetic origin, into both diastolic dysfunction, systolic dysfunction, and heart failure. And when we give CBN1 back, we actually restore function. So mouse work are great, but we're not going to do well if we just sort of save a few mice that we hurt along the way. And so we moved, and this had happened when I moved.
I'm sorry,
to,
Robin,
4 years
Dr.
ago.
Shaw?
Yeah, please.
Before we go into this one, can you go back one slide?
Sure.
I just have I'm struggling a little bit with this concept of BIN1 and the microdomains. And a little bit more, if you could tell us about BIN1. Is it involved in a signaling pathway? Is it simply a transmembrane domain that's providing structure? Is it in which case is it associated with the actin myosin or the cytoskeleton in some way? Tell us a little bit about that.
Yeah, it's great, and I'm sorry I skipped some of the background on CBN1. CBN1 is, we call it CBN1 because it's the cardiac isoform of a richly spliced protein. It's called a bar domain protein. Another name for it is amphiphysin 2. It's not a transmembrane protein. It's a membrane sculpting protein. And by that, it has a membrane affinity domain. That's its N-terminus. Its N-terminus is quite lipophilic. And then it has at the C-terminus, it has more of a traditional hydrophilic domain, which allows the cytoskeleton to hang on to it. It's shaped like a hockey, a boomerang, if you will. And, sometimes we draw it in yellow as the banana protein. It's got a natural curvature to it. And depending on how these bar domain proteins stack, they actually form different curvature. They can wrap membrane at different angles. A lot of basic science has been done on bar domain proteins. One of the classic ones is Peter D. Committee's done a lot of this work at Yale, and that it can form endocytic vesicles, and it actually helps in the endocytosis process. So basically how these bar domains come together is how it forms membrane curvature. And so what we found is that this particular one, cardiac bin-1, it has, for the aficionados, expresses exons 17 and 20, and 13 and 17. And the cardiac bin-1 with 13 and 17 occurs at T-tubule membrane. And so before you get to the sarcomere and the actomyosin, it's actually at the T-tubule invagination. And there it is basically organizing the proteins that are responsible for the calcium transient. So this whole question actually originated years ago when we asked the question, how does calcium channels go to T-tubules? It's been known that calcium channels go to T-tubules forever. How do they go there? And it turns out that calcium channels are going to the cardiac bin-1 that's at T-tubule membrane. That's what helps calcium channels traffic move to cardiac membrane. And then with subsequent studies, and a former postdoc and longtime collaborator, Ting Hong, has done a lot of this work. She's now at Utah as well as an associate professor in pharmacy. And that basically cardiac bin-1 forms baskets of membrane that not only collect calcium channels, but collect renin receptors, which are, opposed to them to form the cardiac dihead for calcium entry, calcium release. Also collects circuit 2A. So basically, whatever controls the calcium transient, these membrane domains are there to organize it. And cardiac bin-1 is downregulated in all kinds of heart failure. It's transcriptionally downregulated in all kinds of heart failure. And so, early work, which I don't have time to show, is we developed a blood test of cardiac bin-1 that lets us assess whether or not a heart is failing. And that was cardiac bin-1 gets off into the blood. And we basically assess that as sort of dipstick of the heart or the biochemical remodeling of the heart. And then the next question, the work I'm touching on now, is when we give back cardiac bin-1, can we restore myocyte health and therefore restore heart function?
Thank you.
And so with that, we moved to actually large animal models. And so in the large animal models, there's a couple of models I'm going to present to you today. The first is a canine ischemic cardiomyopathy, and this is a model championed by Derek Dosdell at the CVRTI. Mohammed Khan is this incredible fellow whose work I'll be presenting over the next few slides. And Doug Smago is a really talented cardiothoracic surgeon who really designed the approach where we do a thoracotomy, tie off the left anterior descending artery to both proximally and distally, and then as well as the collaterals, because dogs are highly collateralized. And essentially, we create a huge anterior infarction. And then, we sort of stitch the animal back up and we wait. And so invariably, this is ejection fraction by echocardiogram. And invariably, after we cause a big anterior MI, the EF goes from the mid-50s to the mid-30s. And then there's always a 2 or 3 week recovery, probably stunned myocardium coming back. And then after the 2 or 3 week recovery period, there's progressive loss of function, progressive loss of left ventricular function. And that's sort of the money of chronic heart failure. Not just the initial insult where the heart loses its ability to contract or relax or both, but actually the subsequent increase in left ventricular and diastolic pressure on comes neurohormonal system that further insult the heart. And hence we get progressive, in this case, progressive ischemic dilated cardiomyopathy. And we basically came up with our first protocol, which is once we fall to an ejection fraction less than 40% in humans, that would be going from mild to moderate plus left ventricular dysfunction. We confirm with NT-proBNP, and then at less than 40% with a high NT-proBNP, we inject CBIN-1. And the way we inject CBIN-1 is we do an endocardial injection. This is using the Nova MyoStar catheter. and we do it to the 20 different locations throughout the left ventricular endocardium. And then we sit back and watch what happens. Here's when we inject a negative control, a GFP negative control. Within 5 weeks of the EF falling less than 40%, invariably the animal dies, or we're obliged to terminate it due to severe heart failure symptoms. But when we inject CBN1, what happens is actually quite a rapid recovery of function. Here's a second. I'll get to the summary data here for the sake of time. We've done about 6 animals treated with CBN1 at this point versus 4 animals treated with the negative control. And invariably, we get a fantastic response of left ventricular function in these ischemic cardiomyopathy animals. And these animals all die at somewhere between 5 weeks and 7 weeks, whereas they just don't die, and we just start, terminating them just to study their hearts. And so what we were very excited about is that not only in this one-time application of CBN1 improved ejection fraction, because we're remodeling the cardiomyocytes, the left ventricle starts to actually positively remodel. And so what we have is that at the 5-week mark, we get progressive dilation in both systolic and diastolic dilation of the negatively treated animals. At the 5-week mark, where we can compare apples to apples, we see not only a stabilization of the left ventricle, but the left ventricle starts to shrink. So no beta blockers, no ACE inhibitors, no diuretics. And what we get is the left ventricle getting smaller from a dilated cardiomyopathy, and its function and mortality obviously improve as well. I should mention that some animals improve more than others. In some animals, we had an ejection fraction approaching in the mid-40s and approaching 50%. And we could convince ourselves that the smaller the infarct, the smaller the amount of dead tissue, the smaller amount of dead heart, the greater the recovery. So essentially, we're not recovering dead muscle, but we actually are recovering feigning myocardium that was not directly affected by the ischemic insult, but nonetheless was starting to fail. And by that, I mean the internal myocytes were disorganized or becoming increasingly more disorganized. So we switched to a second model. And in this model, we initiated or induced a non-ischemic cardiomyopathy. We used mini pigs. These are 30 to 40 kilogram mini pigs, Yucatan mini pigs. And we implanted pacemakers, and we drove their right ventricle at a rate of 170 beats per minute. And then otherwise, the protocol was the same. We tracked them by phlebotomy, we tracked them by echocardiogram, and we waited for the time to intervene, which again was less than 40%. So these animals, their baseline ejection fraction is around 70%. And then after rapid pacing, in about 2 to 3 months of rapid pacing, their ejection fraction falls to less than 40%. And at that point, we give therapy. This time around, we said, you know what, it's working so well. Why don't we not just inject it directly? Let's just give an IV therapy and see what happens. And I'll be happy to go into this in the discussion, but it's a pretty low dose IV therapy relative to the gene therapies of today. And what we saw is that in the negative treated animals, when we jump between PBS and GFP, packaging AAV9 virus as a negative control, they die usually within about 2 months. But and here's a couple of animals when we give CBN1 as a gene therapy, one shot intravenously in literally an ear vein, what we see is a rapid improvement in ejection fraction. And that ejection fraction is maintained. Our actually protocol was to go, we're going to keep these animals for 12 weeks just to see what happened. It turns out we needed a lot longer than 12 weeks. And in fact, if we look at the summary data right now, we actually go, excuse me, we go as long as 6 months. And I want to emphasize that we haven't stopped pacing. We keep pacing these animals throughout the 6-month post-injection period, but yet the animals don't lose function, whereas without CBIN-1, the one-time therapy of CBIN-1, they lose function within about 8 weeks. They develop severe heart failure and have to be terminated within 8 weeks, terminated due to end-stage symptoms. And so just to summarize, and I'll get to the arrhythmia work in the next slide.
Dr.
To summarize, the current approach to heart failure is to treat heart failure as a systemic syndrome. And that is, block the neurohormonal pathways that are beating up the heart, beta blockade, renin, angiotensin, aldosterone system inhibition. We diurese, of course. We reduce afterload. We've got SGLT2s that maybe is more in the afterload camp, but again, the science is still out. And then we call in the Marines when we have a truly end-stage disease, refractory to medical therapy, including resynchronization, left ventricular assist device, total artificial hearts, and of course, a heart transplant as definitive care. What we're suggesting is that actually we are reaching the era that we can approach heart failure, we can approach the syndrome of heart failure as a disease of failing heart muscle. We have ways by blood test of actually confirming that the muscle is remodeling. And most importantly, and this is the work I just presented today, we can restore subcellular muscle organization. We can actually, by restoring cardiomyocyte, individual cardiomyocyte organization, we can restore heart function, improving mortality. And so in my last data slide, I want to touch on what Dr. Cook was referring to a little bit earlier. And so to generalize the story further, what we believe we are finding is that when we nudge, and I'm sorry for that technical term of nudge, but when we basically push the cardiomyocyte into a system that improves the trafficking, improves the organization of the cardiomyocyte, we can get away with very low doses of gene therapy to have profound benefits. One of the other molecules that my lab cloned along the way, it was about 10 years ago, is a trafficking molecule for connexin 43. I've been a big fan of connexin 43 gap junctions my entire career. And we identified a key trafficking component of connexin 43 that's actually made by the same mRNA. It's basically this ion channel gene makes its own trafficking, auxiliary trafficking subunits. And we just gave a name. It wasn't very creative. GJ1 is the gene name. Connexin 43 is, of course, 43 kilodaltons with its transmembrane domains. This is basically gap junction without any other transmembrane domains, just the C terminus. And it's about 20 kilodaltons in size, hence the name GJ120K. I'm sorry for my lack of creativity there, but that's what we call it. And so GJ120K, it turns out, is downregulated in syndromes such as arrhythmogenic cardiomyopathy. This is a mouse model of arrhythmogenic cardiomyopathy, a desmoglein loss of function, essentially a desmoglein knockout, if you will, a DSG2. And what we show is that through gene therapy, again, this is back in the mouse, a gene therapy, when we insert GJ120K packaged in AAV9 virus, can restore normal electrical behavior. We can reduce the ventricular arrhythmias of arrhythmogenic cardiomyopathy. And importantly, we're not fixing arrhythmogenic cardiomyopathy. We are actually limiting the phenotype, because a key part of the phenotype of arrhythmogenic cardiomyopathy is downregulation of connexin 43 gap junctions. We can recover localization, and this is in green, of the gap junctions themselves, and the red is the intercalated discs. And what we can see is we recover the actual localization of gap junctions at the intercalated disc. And whilst the mutation is still there, we can limit the arrhythmias. And so, in general, we feel like we're on the precipice of a new generation of therapeutics. And this new generation of therapeutics is not targeted at replacing just a mutant gene or doing bulk replacement of a gene that's terribly downregulated and we just have to pour it into the cell. In fact, we can achieve low dose intravenous delivery of trafficking-related molecules. And with that, we can rescue clinical phenotypes. And very importantly, when we think about the patients who need therapies, we can treat not just genetic origin disease, but we can treat acquired disease. And then just to highlight one final feature, when we do use low dose of these gene therapy, we also happen to be limiting toxicity. As most people in the gene therapy know, much of the toxicity comes not from the sort of gene target itself, but from the high doses that are needed to treat people. And we're using doses that are on the order of 50 to 100-fold less than typical for most gene therapy trials. And by doing that, we don't see the liver or other toxicity that's typically associated with gene therapy and is limiting the broad acceptance of gene therapy to this point. And so with that, I just will finish up by highlighting key individuals who have really done the work that I presented today. As I mentioned, Mohammed Khan is a superstar in Derek Dosdell lab that really drove the ischemic cardiomyopathy work. Jing Li is in my close collaborators at Ting Hong's lab. Pia Balmaceda is Jing's partner in crime, and they've really pushed the non-ischemic tachypacing work in the mini pig. And then just a shout out right now at the CVRTI at the University of Utah, we have 16 investigators, about 120 people. When I say 16 investigators, 16 investigator laboratories, close collaborators amongst those 16 on the work I presented today. I start with Dracos, Ravi Ranjan, Ting Hong. Special shout out to Joe Palatinas, who did the arrhythmia work, and now Joe has his own lab at the CVRTI. From cardiothoracic surgery, Derek Dosdell, and our chief of cardiothoracic surgery, who's also an amazing investigator, Craig Salesman, are strong contributors to the work I presented today. We just completed at the CVRTI our fourth wing. Sorry, this is the advertisement portion. Our fourth research wing. And so we're recruiting new folks. We always have a need for trainees, early career folks in this, both students and postdoctoral fellows. And we also have space for at least 3 to 4 new investigators. And we have a couple of searches underway for investigator positions as well, faculty who may be interested. Anyway, with that, I'll leave it alone. I'm happy to answer any questions, but thank you for the opportunity to present this work today.
Thank you, Dr. Shaw, for that outstanding presentation. Really intriguing work on potentially a new therapeutic avenue for heart failure, actually 2 new therapeutic avenues. And we had some questions come up during your talk, and I think I'll let Dr. Lai ask those questions.
So, Dr. Shaw, great talk. I'm very impressed by the pig study, actually. But I'll start with the questions that are coming from the audience. So the question was, utilizing the AAV C-cabin delivery, which can potentially target all cardiac cells, have you investigated its effect on non-myocyte cells within the cardiac tissue? So actually, because you mentioned the low dose that I use, so also I'm interested whether it is also through, it's a combination a combination effect coming from the cardiomyocyte or non-myocyte cells. So would you share some insights?
It's a great question. When you're holding a hammer, everything looks like a nail, right? Mm-hmm. So I want to believe that we really, and this is sort of on the strength of a couple of decades of science, that we're positively remodeling the T tubules, and as a result, increasing function of the organization of function of the cardiomyocyte, and not rule out non-myocyte contribution. You're absolutely right. And to be clear about this construct, in both cases, we use a CMV promoter. So we're not using a muscle-specific promoter. We actually looked at muscle-specific promoters, such as use of troponin promoters, and did not find the expression sort of matched anything close to what CMV can do. And so we've stuck with CMV. We haven't fully ruled out a non-cardiomyocyte contributor. It would be interesting. Ting Hong and I have a grant looking at, excuse me, the interplay between cardiomyocytes and non-cardiomyocytes with this in mind. And as you suggested, and some of our work has shown, that CB1 as a membrane sculpting protein basically forms microparticles that do get released both locally and into the blood. So there could be a significant contributor. We just don't know what it is yet.
Yeah. We have a little bit of a bias here because we've been looking at the endothelial cell dysfunction in heart failure, and we have some data that'll be coming down the pike about the recovery from heart failure as a vascular recovery, but that's another story. I love the work with BIN1, and we were particularly, both of us were impressed by the pig study. You were continued pacing the animals, and yet they were resistant to dysfunction. That was quite amazing. So it's more than a treatment; it's also a preventive.
Yes, we understand the practicalities that we're never going to be able to prevent heart failure without showing that we can treat it first, when we go to human. But yes, we have mouse data that CB1 introduced to a wild type animal, wild type heart, non-failing heart, induces an athletic heart phenotype. The heart gets actually a little bigger, slower, much more efficient. Many of us have been in the echo lab where we've seen, hey, is this a cardiomyopathy or is this an athletic heart? And it's the latter. And so yes, we're actually astounded that the function was resistant to the pacing. We've post-treatment continued pacing. We've initiated the process that will sort of go to FDA approval. We want to get to the point of a clinical trial in about 2025. And our initial target will be the class 3, sort of 2-3 CV kind of patients. But essentially, we want people with cardiomyopathy that are still functioning. And just as you say, ideally, if we prove efficacy in this population, we'll continue to sneak upwards or earlier in the heart failure spectrum, because we do believe we'll be able to forestall the onset of severe disease.
The fact that CBIN is impaired in all manners of heart failure, you said non-ischemic, ischemic, and it seems as though it's maybe a secondary phenomenon. It may not be the primary cause of the heart failure, but it's a secondary contributor. Do you have any ideas, any thoughts about how the various forms of heart failure are all having this effect to knock down this important sculpturing protein?
Absolutely. I have guesses. These are great questions. I have guesses. I don't have answers. So yes, just as you said, we're not affecting the insult. So we're not affecting, whether it's ischemia or pacing, we're directly sort of engaging whatever ischemia or pacing does directly. This is sort of subsequent after the insult or during the sort of chronic insult. We're helping the myocytes. And so there are stress pathways turning, and this is why neurohormonal blockade works. There are stress when the heart is insulted, when left ventricular end diastolic pressure increases, when the heart has to work harder, there are stress pathways that are turned on. And CBN1 is downregulated. What we can say with confidence is a downregulation occurs at the transcriptional level. There are a lot of cardiac-related promoters upstream of CBN1 and of BEN1 in general. And so we do think that it is secondary to sort of a stress pathway-related downregulation, etiologically making the heart work less hard, at least acutely, helps things out. But what is downstream? What is that signaling downstream? We haven't worked it out. What it is, what the promoters are that get turned on or turned off in this chronic heart failure progression, related specifically to the BEN1 gene. We don't know yet. Obviously we think the adrenergic system may have a lot to do with it, but I'm just throwing out guesses right now. We haven't done that sort of promoter work yet.
Wonderful.
So my question actually is more like a scientist, not a physician. So how do you find this target? So what kind of screening do you use to find this BEN1?
Thank you. I love that question. And so, and just we talked about training at the beginning of the show, and this is where I want to promote the idea that a focus on basic science leads to this translation, more a sort of mechanistic based basic science more so than say a screening approach. Our first question. When I started my lab, I was really on connexin 43, and we had identified, coming out of my postdoc, we had identified how connexin 43 gets to the intercalated disc. And Ting Hong was my postdoc at the time, and her question was, how do calcium channels, which don't go to the intercalated disc, they go to T-tubule membrane? How do calcium channels get to T-tubule membrane? So if we can understand how one protein gets to the intercalated disc and the other protein gets to T-tubules, we'll understand a lot more of how the heart, muscle cells, how the cardiomyocytes organize themselves. And through her work, she identified this membrane deformation protein, this membrane sculpting protein called BEN1. And over time, we ended up cloning, cardiac BEN1, this T-tubule related form of BEN1. And so it actually all started, nothing to do with therapy, nothing to do with diagnostics. It all started with a question, how do calcium channels get to T-tubule membrane? And then at the same time, I was doing a lot of advanced heart failure. This was at UCSF and then down at Cedars. And, we sat on listing committees and saying, how sick are people's hearts? And, as clinicians, we're kind of stink at it. And so with work going on in the lab that understands how heart muscle cells organize themselves, that's where the translation started. But it really did start at the fundamental science-oriented question, how do cardiomyocytes organize themselves, specifically if connexin 43 is used a certain mechanism to get to one area of the heart muscle cell, what is the mechanism that calcium channels use to get another area of the cell, and it went from there.
That's a great story. We have a Center for RNA Therapeutics here, and one of the things you mentioned about connexin 43 is that the RNA transcript for connexin 43 actually contains within it the RNA that encodes the transport protein. And I thought that's fascinating. That's a level of translational control of gene expression. That's very interesting. So there must be like an internal ribosome entry site within connexin 43 that allows for the production of this transport protein. Tell us a little bit about that.
Yeah, you're absolutely right, Dr. Cook, and quite astute for pointing that out, especially since I didn't get into the story. That's just it. There is an apparent iris site downstream that actually probably triggers the formation of 20K. And we think it's a bit of a scanning mechanism that the ribosome, for whatever reason, and again, this goes back to signaling, but for whatever reason, the ribosome doesn't start at the first start codon, and then it slides down and then hits this iris site. The way it works, the internal site, Jonathan Weissman has done a lot of this work in yeast, UCSF. The internal site is still an AUG, encoding a methionine. So basically, every eukaryotic cell has an AUG as the first coding, as the first codon for mRNA, and that's where the ribosome nodes to bind. These internal sites all have AUGs, have methionines, and if for whatever reason the ribosome doesn't start on the first one, it basically slides down the mRNA and hits the next AUG, and not just the next AUG, but there's a particular conformation in the mRNA that it likes 20K more than others. So there are 6 internal methionines for connexin 43 at GJ1, and these smaller isoforms are all produced, but 20K is the one that's most prolifically produced. And so, but basically you nailed it. The mRNA that encodes the full-length protein is carrying its own trafficking molecule. It basically is carrying the signal that helps the full-length protein get to where it needs to go. And the reason it does it is time for another discussion, but it's where we put a lot of work in the lab. It does it by organizing the cytoskeleton. So the GJ120K organizes the cytoskeleton, the trafficking apparatus, the highways, if you will. And by organizing the trafficking highways, that allows this, that literally lays out the physical structures for the full-length protein, for the channel to get to where it needs to go.
Beautiful. This has been a fascinating talk and discussion, and I'm actually going to follow up with you on a few things because I think there may be some opportunities for collaboration between our Center for RNA Therapeutics and the work that you're doing. So let's do that.
I would love that.
Yeah, let's have another discussion. But it was wonderful to have you today on the show. Thank you so much, Dr. Robin Shaw. You just heard his discussion about his wonderful work with arrhythmogenic ventricle and understanding the mechanisms of heart failure. Thank you so much.
Thank you.
Thank you. It's been a real pleasure. I really appreciate the chance to present. And again, it's an intimidating audience, so thank you so very much.
Thank you, Robin, and thank you all for joining us at the cutting edge of cardiovascular science today.
Bye-bye.